دكتور إيهاب شحادة. He's a consultant gastroenterologist, hepatologist, chief section of gastroenterology hepatology unit of King Hussein Cancer Center. He's going to talk colorectal cancer, screening and prevention.
السلام عليكم. أنا عارف كلكم بدأتوا تتعبوا وتجوعوا. I want to thank the organizing committee for giving me the chance to talk to you all. My talk is going to be somewhat brief, but very important topic for the primary care physicians to know about: colorectal cancer screening. Cancer is the second most common cause of death in Jordan, believe it or not, after cardiovascular disease. We are going towards the mortality and morbidity and disease prevalence comparable to the Western world. So infections are really very low in the Western Jordan as a cause of mortality, while cancers come only second to cardiovascular disease. In 2009, over 550 cases of colon cancers were documented in Jordan, and overall, for the past 20 years or so, the numbers have been rising very slowly. We don't know whether we're picking up more cases or we're developing more cases. Now, this is just to show you the 10 most common cancers in Jordan, and after breast in females, colon cancer comes second. And it's the single most common cancer in men, and comes second in females after breast cancer. There's a myth that colon cancer or cancers in general are very common in Jordan. Well, they're not. We are actually comparable to all the neighboring countries, and we still stand around 30 to 40% compared to the Western world. The most common type of cancer, colon cancer, is adenocarcinoma, whether it's in the colon or in the rectum. And as a gastroenterologist and even oncologist, we like to divide colon cancer into either colon or rectum because the treatment and the approach is actually different, and somewhat the prognosis is different. And even the chemotherapy regimens can be somewhat different for these two types or two locations of the cancer. Now, what are the factors that cause cancer? Now, this is a very common question for lay people. What's causing cancer? Now, we really don't know. We know it's a multi-het procedure. We know you have a genetic predisposition, and then you have environmental factors. But now several studies have associated the lack of physical activity, consumption of red meat, obesity, cigarette smoking, and alcohol use with colon cancer. So all of these have some sort of association with the development of colon cancer. Now, what can you do as a person to kind of cut down on the chance of developing cancer? Some multivitamins containing folic acid have some weak evidence. Aspirin and other NSAIDs have some evidence. Postmenopausal hormonal use, calcium supplementation, selenium, and consumption of vegetables, fruits, and fibers. So if you want to recommend to your patient, which one among all the one things on the right to prevent cancer would you recommend?
Fruits.
The only thing that you would actually recommend is probably consumption of vegetables, fruits, and fibers. Not a single one of them is useful on its own. It's the healthy diet. Have a healthy diet, have a lot of fibers, vegetables, and fruits, cut down on the red meats, don't smoke, and don't become sedentary, exercise. Those are the things that are simple and you can recommend. What about all the other ones called chemo prevention? I'm going to touch just slowly on a little bit about this toward the end of my lecture, but none of them are cost effective. If you want to prevent cancer, none of those are indicated just to prevent cancer. The only one that has been shown to be somewhat cost effective, if used for cardiac etiology, is the aspirin. So if you're using aspirin to prevent cardiovascular disease, that's useful for colon cancer. But if you're using it purely to prevent colon cancer, then definitely it is not cost effective. Now, as all other cancers, cancers are a function of age. So you develop cancer as you age. There are much more cancers in the elderly than there are in the young. We think in Jordan, the colon cancer tends to start somewhat early. If you can most of the Western world, the cancer starts above the age of 50. Now we have slightly higher percentage of patients that actually come between the age of 45 and 50. So maybe we're like the blacks in the US, we're developing cancer at a slightly earlier age. Now this is again a function of the age. This is the general population. And remember, it starts rising above the age of 50, the incidence of cancer in the general population. Well, if you have some sort of genetic syndrome, first it starts at an earlier age, and then it rises sharply thereafter. So we're going to run some definitions here. What is screening? This is important, because when you discuss this with your patient, you tell, okay, I want to screen you for colon cancer. You say, okay, I don't have any symptoms. Well, that is the definition of screening. Because if you do have symptoms, then we're doing diagnostic workup. This is not screening, this is diagnosis. While on the other hand, if you're doing some sort of test to look for a cancer or something medical with no symptoms, this is basically the definition of screening. What about surveillance? Surveillance, on the other hand, is that you already were identified to be a high risk for that cancer. You had a cancer, and we're going to follow up for further cancers or polyps. You had polyps, and we're going to further look into developing more. This is called surveillance. So you've had a primary or personal history of a pathology, and we're going to follow on that. While diagnosis is when you have symptoms, and we're looking to find out what's causing that. This is a statement from the Jordanian Cancer Registry. They say a healthy lifestyle and a healthy diet will prevent 1/3 of all cancers. Another third are curable if detected early and treated properly. This is from King Hussein Cancer Center in 2008, and you can look to see that most of the cancers that were diagnosed that year were stage 3 and stage 4. So we're really not picking up the cancers. We have very good treatment now for colon cancer. And you can easily treat and cure these patients if you detect them in the first 2 stages where the 5-year survival is over 70 to 90%. So we need to detect those cancers early. So people would talk about cost. Is it cost effective to screen for cancer? Now there are several answers to that. And the main answer depends how much money is that country making, what's the main problem health-wise in that country, and basically how much are you willing to spend to prevent or to prolong someone's life. Now, one of the best articles I've seen about this was from the WHO in 2010, and they divided the world into 3 main regions. We fall probably into region 2, where really we don't have much of mortality from infectious disease or newborn mortality. Those are really, we are very equivalent to the West when it comes to infections and newborn mortality. So we fit into that main middle criteria where we have good health, but on the other hand, we don't have a lot of money. And they say some sort of screening. Now, pick one. All of them are considered to be cost-effective in this setting. So if you want to compare colon cancer screening to other modalities that we do, there are only 2 other things that we really do that are more cost-effective, which is using low molecular weight heparin to prevent DVT in the appropriate setting, screening for hemochromatosis, of course, in the West, not very common here. But then everything else, including even aspirin to prevent heart disease, is less cost-effective. All of these measures are less cost-effective than screening for colon cancer. So some sort of screening for colon cancer is probably cost-effective, even in our country. So what makes screening for colon cancer so special? What makes screening so special is that we know that 90% of cancers, they develop through what's called adenocarcinoma sequence. And that adenocarcinoma sequence takes anywhere from 7 to 10 years to develop. So between developing an adenomatoous spot, whether it is a polypoid lesion or a flat adenoma, those go gradually through dysplastic changes, and then they develop into cancer. So you have those 7 to 10 year period where you can detect either a polyp, remove it, and subsequently your intervention will prevent cancer, or you can detect the cancer at an early stage before it metastasizes to the regional lymph nodes or to distant areas. So subsequently your treatment for that cancer will be much more effective. There are key elements for successful screening. first know that screening now is proven effective for colon cancer and is considered the standard of care. So if you're not offering your patients screening, you're not doing them a favor. Screening for colon cancer is based upon stratification. So we stratify the risk of developing cancer in your patient in front of you into high risk or average risk. If they're average risk and they're 50 or above, whether males or females, you offer them the screening options for average risk. And you always offer options because patients may like one option and defer the other one. Now, if you have a screening test that turns out to be positive, such as fecal occult blood, if you don't follow that with colonoscopy to find out what's causing that fecal occult blood, then it's useless. You need to follow up on all your positive screening tests, and if you diagnose those pathology, you need to treat them appropriately and timely, and then do surveillance to prevent further pathology. Around at least 75% to 85% of colon cancer is sporadic. So around 80% or so of your population will fall into the average risk. What are the other risks? The other ones are if they have family history, especially first or second degree relatives. First degree relatives, especially at a younger age, below the age of 60, will raise your chance of developing cancer 2 to 2.5 times. If you have 2 second degree relatives with early cancer, again, 2 to 3 times the risk of the normal population. So you fall into a higher population and higher risk, and subsequently have more different options. Then the hereditary syndromes are really rare, and then it's important to know that inflammatory bowel disease, like Dr. Keepak mentioned, really are considered high risk, and screening in those patient population is really very important because the incidence of cancer after 20 or 30 years of colitis is very high. Guidelines. We always like to talk about guidelines. There are so many guidelines, depends where you want to look, which one you want to take. If you like one or the other, please stick to it, that's fine. Some sort of screening is better than nothing. There's so many recommendations. And the one I like to talk about is the multi-society task force, because basically in the US they had different organizations sit together and then decide on what would be the best options. Now this is the latest, this is 2008, and they decided to look at the different options for screening for colon cancer and divide into 2 main categories. The first one is that the ones that can prevent cancer. How do they prevent it? By basically detecting the precursor, which is the polyp, and removing it. Subsequently, you even prevented the cancer to start. And then the other group is the group that detects basically cancers or occasionally advanced polyps before they develop into cancer. So the first group is basically all some sort of imaging study. Flexible sigmoidoscopy every 5 years, starting at the age of 50 for average risk. All of these options are only for average risk, remember that. For increased risk, they have completely different pathway. But I'm going to discuss with you as primary care, the average risk. Colonoscopy every 10 years. So one single colonoscopy, you don't have polyps, you're good to go for at least 10 years. And some talk about cost effectiveness, maybe even a lifetime. One colonoscopy somewhere between the age of 55 and 60 would be cost effective. Double contrast band element. Remember, double contrast, not a single contrast. Effectiveness in the range of 50%. Colonoscopy, sensitivity and specificity in the range of 90 to 95%. Sigmoidoscopy in the range of 50%. And then CT colonography, or what we like to call virtual colonoscopy. It's a CT scan that basically will process the imaging after thin cuts to look for polyps, and we're going to touch about this in a second. Now, what are the other tests that actually detect only cancers or potentially, sometimes large polyps? The fecal occult blood, and this has to be done annually, meaning every year you have to take 3 samples to check for white blood. Now, those needs to be tested by a high sensitivity test. Not hemoccult 2, we need hemoccult sensor or something like that. But really high sensitivity hemoccult test. 3 samples on 3 consecutive days. A week before that, you're not supposed to take red meats or vitamins, especially vitamin C, that will give you false negative test. So if you do that annually, then you're really getting some benefit. And this is very easy and cheap and available in Jordan to offer to your patients. Now, a better test is the fecal immunochemical testing. This is fairly new and was added only in 2008. It's not available in Jordan, but it's a better test to detect human blood in the the stool. So it's actually a better test for stool testing for blood. Now, what about testing for DNA in the stool? It's available. The first time it was added to the guidelines was in 2008, and I'm going to just touch about the comments here from the Multi-Society Task Force. They say there's no harm or benefit, so remember the statement, from using the DNA testing in the stool or using colonoscopy. So that's an important, I think, statement touching about this might be useful, but I doubt that it's cost effective. So which test do you offer your patient? This is the algorithm or the options that we look for or we touch upon when we discuss with our patients. Of course, as a primary care, you don't really have to know all of this, but remember one thing. Offer them all the options. Tell them, okay, there's stool testing. It's somewhat useful. There's flexible sigmoidoscopy every 5 years. It's also useful. You have colonoscopy every 10 years. Now, if he asks you what's the difference, now, if you go into the test that detects cancer and prevent it, or detect polyps and prevent cancer, that's probably more efficacious, but it goes with a higher cost and somewhat invasive. On the other hand, if you go into the test that will only detect cancer at an early stage, it's cheap, it's easy doable, it can be done anywhere, except in the Ministry of Health 2 years ago, 3 years ago, they did not have congenital blood. I'm not sure whether there was someone can tell us whether they have it or not, but it's a simple test. So doing something is better than nothing. The more invasive you go, the higher the cost, and the slightly increased risk of complications. Comments about the guidelines from the American College of Gastroenterology. American College of Gastroenterology in 2008 also made some changes to their recommendation, and they think that colonoscopy is their preferred test, so they prefer colonoscopy. Now they added the stool fecal immunochemical testing, and they consider the African American at a higher risk than white Americans for cancer, and subsequently reduced their age to 45. So African Americans, according to the ACG, should be screened at age 45, not 50. The Multi-Society Task Force, again, had the same recommendation, which is fecal blood, 3 samples, 3 days annually, sigmoidoscopy every 5 years, colonoscopy every 10, but they said there's no harm or benefit from adding or doing this stool DNA testing or the CT colonoscopy. We like colonoscopy, we are gastroenterologists, we like interventions, we like to see and we like to prevent. So colonoscopy is our preferred test, and if you look into the community of the GI, the single best offered test, and this probably is somewhat a mistake, they tend not to give options, which I think we should give options, but if you ask us which one we prefer colonoscopy, of course. It's more sensitive, it's better, you use colonoscopy after all the other screening tests to prove or disprove the pathology that we have. It is the gold standard for sensitivity. It offers a single session. You can diagnose the polyp, remove it, even big polyps, precancerous, you can remove them, and you can diagnose at an early stage and hopefully prevent cancer by removing the polyps. Now, as we said, you can prevent cancer or diagnose it early. It has, believe it or not, a high patient satisfaction, especially if you're using sedation. If you offer a patient colonoscopy or a barium enema, which one do you think he's going to be happier with? I can tell you he's going to be happier with the colonoscopy. We do the same thing, we inflate the colon with air, they're uncomfortable, but with one procedure we give sedation, they're happy. And the other procedure with the double contrast barium enema, they don't give any sedation. It's uncomfortable. It's a 50% sensitivity for the double contrast barium enema. It's 90% plus for the colonoscopy. Now, on the other hand, the cons, the reimbursement can be an issue. In the United States now, Medicare considers screening average risk patient to be covered. So this is really, people are going towards screening. Even insurance companies recognize that this can be cost saving for them on occasions. And if you go with colonoscopy, there's a 0.2% chance of perforation, which is like 2 in 1,000 of diagnostic procedures. Now, we know we're not 100%. We're missing cancers. We know there's a trend of cancers to grow on the right side instead of the left side now. And we know that some patients who have colonoscopy still develop right-sided colon cancer. Why? So we know we have faults. We're trying to improve. Now we have better techniques. You have narrowband imaging, you have chrome endoscopy, endocystoscopies. They're developing now 3 cameras that have better view instead of the 170 or 120 angle that we see in. There are cameras now that will see 230-degree angles. We do retroflexion in the cecum to pick up more of the right side. So we're trying to improve even on colonoscopy to prevent more and more cancers. And I'm not going to touch on the ulcerative colitis because my colleague has, but remember that ulcerative colitis or Crohn's colitis are precancers. If you have more than 8 to 10 years of the disease, you should start screening, and we can pick up diseases that are very difficult to pick up by regular endoscopy, and you can help take the colon out and prevent cancer in that patient. So what are the emerging screening tests? Virtual colonoscopy now is on the guideline. People would really like to do some sort of imaging. Capsule endoscopy is also one of the newer techniques. They have pros and cons. It's not interventional. They only look for polyps above 1 centimeter in size, which are the important polyps. But again, they're still not 100% proven. This is how the polyp would look on the virtual colonoscopy. This is the DNA testing. Now, before we go to the DNA, this is a survey that I carried out like 3-4 years ago in a GI community. And these are answers that were carried out by the physicians themselves, not the patients. Reason for refusing the test by the patient. The physicians think that 31% of patients refuse the screening test because of cost. So if you offer them a colonoscopy with 400 or 500 JD cost, they may say no. But if you offer the people with blood, on the other hand, with 15 JDs, they may say yes. So you have a third of your population that you can screen by giving options. Fear of results, this is important, and it's covered by education. Lack of symptoms, again, tell them that's why we're screening them, because you don't have any symptoms. So if you look into all of these, basically, you can find out that we have more room to improve in bringing more patients to screening. This is the genetic testing. We do stool DNA testing. This is probably the single best study for them, and they're really good. Well, somewhat good in looking at cancers, better than wide stools, but definitely nowhere close to colonoscopy or imaging studies. What about chemoprevention? Can we just give medications and prevent cancer? Well, we know that cancer goes through several stages and several insults with genetic mutations. And as we said, aspirin, other NSAIDs, folate, and calcium work at one place. But the only cost-effective is using aspirin for preventing heart problems, and that's been shown to be useful to prevent some of the GI problems. But if you're using any of these, first, most of them have been shown either to have very weak evidence or no evidence at all, and the only thing is that they're not cost-effective. This is the algorithm. This is much simpler than it shows. You get your patient, you evaluate their symptoms. So you get your patient and you evaluate their symptoms. If they have symptoms, then you're not screening, you're doing diagnostic tests. If they don't have any symptoms, then you evaluate their age, their risk. Average risk, you look at their age. If they're still young, they don't need any screening. If they're 50 or above, then you offer them options. The options we just discussed. Any of them is good. Any of them is better than nothing. And if you have any of those tests that shows a positive result, you need to do colonoscopy. So evaluate them with colonoscopy. If it's a polyp, remove them. If it's a cancer, you send them to surgery. If it's nothing, then reassure the patient. Now, on the other hand, if they have a higher risk, this is the second group that you probably, as primary care, should send to the gastroenterologist. But then you look at the history. Is it family history or personal? If it's a personal history, you do surveillance colonoscopy. If they had cancer or polyps in the past, you cannot do fecal occult blood or fecal immunochemical testing or stool gene testing or whatever. You need to do surveillance colonoscopy for those patients because they're high risk. If they're IBD, again, you need to do colonoscopy. If they have positive family history, it depends on the history. If it's a genetic syndrome, each one has its own set of rules and guidelines for screening. If you have family history, 1 first degree below the age of 60 or 2 second degrees below the age of 60, again, that's like 2.5 to 3 times the normal risk of people, then those need colonoscopy. Colonoscopy will be done either at the age of 40 or 10 years younger than the relative, whichever comes first. So whatever comes first, either 40 or 10 years younger. Now, if you have a personal history of colorectal cancer or polyps, and you have average risk, if you have colorectal cancer or adenoma and a first-degree relative, but he was older than 60. When he got the polyps and cancer, he was above the age of 60. You actually have an average risk screening and start at the age of 50, but you need to make sure that these patients will follow your recommendations. So what does it take for screening to work? It takes a team to ensure colorectal cancer screening is successful. You need physicians that must recommend the test. Patients must accept the advice, and insurer must pay for the screening and the follow-up test. Thank you very much.
Thank you, Dr. Ihab. Thank you, Dr. Ihab, for this comprehensive talk. And of course, open for 2 questions. Dr. Junaid.
Thank you very much for such a comprehensive talk. There's a new trend in the States now, whereby every time you find cancer colon, they are looking for Lynch syndrome. I was wondering, what's your experience in the center? Whether you have carried this trend or not, especially in females, where they also have cancer of breast at the same time. Thank you.
Yes, thank you very much for this question. Now, the new trend is that we know that not all people will go through a 7 to 10 year period of time to develop cancer. Unfortunately, we like to have everybody go through that 7 to 10 years, but it's not true. There are people now with what's called microsatellite instability. And even now, any patient with cancer, once you resect cancer, as part of the standard report, especially if you go to KHCC, is to show any signs morphologically on the pathology, any signs of microsatellite instability. They have some sort of criteria that they can look at. And if they do have those signs, then they will do immunochemical testing for the MSH2 and MLH1 and some of the other genetic mutations through not genetic discovery, but immunochemical testing on the cancer or the polyp. And now the new trend is trying to see whether the patients are growing their polyps too fast, or they develop at too early of an age, or they have too many family members, but no specific criteria to fit Lynch syndrome, for example. If you have 2 family members, they're below the age of 50, you don't have a 3rd person that developed cancer or colon cancer or a cancer associated, then those are the population that you need to screen for microsatellite instability. So this is the idea, is to look for microsatellite instability on people that develop cancer, either at an early stage, they develop too frequent of polyps or cancers, and they don't fit the criteria for any of those Lynch syndrome or FAB or anything else. You need to look for microsatellite instability.
They're doing it irrespective of age.
I will not be familiar with that. I'm sorry.
Thank you, Dr. Ihab. Thank you all for listening to our session.